Để tiếp theo chương trình thì tôi xin trân trọng giới thiệu giáo sư tiến sĩ Masanori Inu đến từ Nhật Bản, trường đại học Keio và một chuyên gia có rất nhiều kinh nghiệm trong lĩnh vực là nút mạch, điều trị các cái bạch mạch và đốt sóng cao tần. Thì giáo sư Inu sẽ đến từ hiện đang công tác tại trường đại học Keio Nhật Bản ở Tokyo và đã làm nghiên cứu, làm nội trú cũng như là thực hành ở nhiều năm ở bệnh viện Kawasaki và đại học Keio University, và hiện tại đang là trưởng đơn vị chẩn đoán hình ảnh can thiệp và điện quang của đại học Keio University. So up next I would like to introduce Dr. Masanori Ino from Japan. He's come from the Keio University Hospital and the university's Faculty of Medicine. Dr. Keio Masanori Ino have many experience in embolization, especially AVM and lymphatic interventions and cryoablations also. Và cái chủ đề giáo sư sẽ trình bày của chúng ta ngày hôm nay sẽ một cái bài báo cáo về đốt sóng cao tần u phổi. And the topic of Professor Masanori Inu will present today is the lung ablation. So please welcome Professor Masanori Inu.
Thank you for a very kind introduction. And it's my great honor to be here and to make a presentation about the lung ablation. It's my disclosure. So that today's agenda include a basic issue about the ablation, and then I'll move on to the basic aspect of the cryoablation. So that especially today I'd like to focus on the cryoablation of the lung tumor. So as you know, there are several types of the ablation, including the chemical, thermal, and electroporation. So that of course the high temperature ablation, that means the microwave and the radiofrequency ablation, is the most popular to treat the lung, liver tumors. And however, of course, the cryoablation is not so popular. However, cryoablation has some advantage over the RFA, I think. So the electroporation is very limited. It's used in the very limited countries, so we don't have any experience. So as for the image guidance, of course, ultrasound, CT, and MRI is very popular. However, among them, the CT guidance is the most popular for the lung ablation. So this is a schematic drawing of the RFA of the lung tumor. So the RFA is the most powerful ablation, which causes the degeneration of the cells and tissues. Of course, the RFA can destroy the cancer cell, and also the damage on the collagenous tissue, which results in the bronchial stricture or the injury of the vessel. So as you know, if the injury of the pulmonary artery occurs, there is a high risk of the massive bleeding. And also there is a thermal sink effect, which can be the reason for the incomplete ablation. Especially that there is a large vessel near the tumor, there is a risk of the incomplete ablation. And the great advantage of the RFA is the availability. I think that most hospitals has the RFA devices in their hospitals. So next is the cryoablation. So cryoablation causes the cell rupture and also the preserve the collagenous tissue. It's a big difference between the RFA and the cryoablation. So the cryoablation can preserve the collagenous tissue so that there is a less risk of bronchial stricture and less risk of the massive bleeding due to the injury of the pulmonary artery, I think. Of course, there is a thermal sink effect. And also during the procedure, cryoablation is less painful. Patients don't feel the severe pain. It's also another great advantage of the cryoablation. However, cryoablation doesn't have the hemostatic effects, so there's a risk of the minor bleeding from the puncture site. And also, disadvantage is the availability, because I think that almost all hospitals don't have the cryoablation unit, I think. So I'm sorry, it's a very old data. So at that time, of course, the RFA and the cryoablation for the lung tumor was not covered by the health insurance system. However, in Japan, many doctors perform the RFA of the lung tumor, and the number of the cryoablation for the lung tumor is very limited. And to tell the truth, from this year, only RFA of the lung can be covered by the health insurance in Japan. So next, I'll move on to the basic aspect of the cryoablation. In the 1980s, the cryoablation was performed under laparotomy or the thoracotomy using the liquid nitrogen device. However, around the 1990s, there are two very important innovations occurs. First one, Dr. Isoda reported the visualization of the ice ball on CT and MRI. So that means the image guidance. And the next, the Joule-Thomson effect using the high pressure argon gas. By means of the Joule-Thomson effect, very thin cryo needle was developed. So that now we can perform the cryoablation using this very thin needle under CT fluoroscopic guidance. So we performed the experiment to compare the temperature change between the liquid nitrogen device and the Joule-Thomson machine. As you can see that the Joule-Thomson machine can obtain the very rapid freezing compared to the nitrogen device. So I mentioned later, but the rapid freezing is very important to cause the cell rupture. So this is the MRI image of the ice ball. On the MRI, of course, you can see the ice ball very clearly like this black signal void. However, of course, we don't have the open MRI, so it's not so popular to use the MRI for the image guidance. This is a CT guidance. We treat this musculoskeletal tumor using the cryoablation under CT fluoroscopic guidance. Of course, you can see that the ice ball is clearly visualized like the low density mass, like this. So, of course, the CT scan is very useful for the image guidance. So, what is the mechanism of the cell death from the cryoablation? So, the slow freezing causes the ice crystallization of the extracellular fluid. Finally, this destroys the cell membrane. However, rapid freezing causes the ice crystallization of the intracellular fluid. And also the ice crystallization of the intracellular fluid occurs the destruction of the cell membrane completely and also destruction of the intracellular organelles. So finally, which result in the DNA fragmentation and cause apoptosis. So the rapid freezing is more effective to treat the cancer compared to the slow freezing. That's the reason why the Joule-Thomson machine is more effective compared to the nitrogen machine. Also the collaboration causes the injury of the microvasculature, which has additional effect. So also other factors affecting cell death is the temperature and the repetition of the freeze-thaw cycle. So the lethal temperature differs depending on the organs and also the tumor type. So usually normal tissue and benign tumor, the lethal temperature is less than minus 30 degrees Celsius. However, in the malignant tumor, it is believed that most of the lethal temperature is around minus 40 degrees Celsius. Also, the repetition of the freeze is very important. In general, double freeze-thaw cycle is performed for the treatment of the solid organs. However, for the lung, usually we perform the 3 times freeze-thaw cycle because in the first freezing is there are massive air in the lung tissue, as you know. So the thermal conductivity of the air is very low. So that the first freezing cycle is intended to cause the bleeding in the lung. Then second and third freeze-thaw cycle is intended to cause the cell death. So we perform the, of course, experiment. We make this device. In the center, you can see the cryo needle. And so around the cryo needle, you can see the multiple thin needle. This is the thermocouples, so that we can measure the temperature around the cryo needle using this device. So we puncture the porcelain lung using this device and perform the cryo ablation. As you can see, this is the isotherm radius, the change of the isotherm radius. So red line is the 0 degrees Celsius, and the green line the minus 40 degrees Celsius. As you can see, in the first cycle, the radius is very smaller compared to the second cycle and third cycle. So this is a reason why the first we need 3 cycles to treat the lung tumors. So how about the pathological change after the cryoablation? But I am a radiologist and not a pathologist, so I don't know detail about the pathology. But we perform the cryoablation of the porcelain lung. Then we remove the lung and make the specimens. So in the center of the ice ball, you can see the completely coagulation necrosis. And bronchiole and vessels and other structures are not distinguishable. It's a complete necrosis. However, in the peripheral region, you can see the hemorrhage, however, without destruction of the structure, because the cryoablation can preserve the collagenous architecture. So in the peripheral region, you can see the bronchiole like this. It can be preserved. So between the 2002 and 2016, we performed the multiple lung cryoablation. However, unfortunately, after that, the regulation of the government became stricter, so we stopped the cryoablation of the lung. However, from this May, we started the cryoablation for the lung tumor again. Anyway, at that time, we used this cryocare machine by the Endocare. This is a very old machine. And now we use this visual ice machine by the Boston Scientific. It's a very user-friendly machine. You can see the big touch screen. And also we can use at most 10 cryo needles simultaneously. So this new machine has 2 types of the needle. 2 types of the puncture needle, each of which can make an oval or spherical ice ball like this figure. And the diameter of the ice ball is about 24 millimeters. We use this needle to treat we treat the RCC of the kidney, mainly. I would like to skip this slide. And so we'll move on to our result of the cryoablation of the lung, more than 15 years. Of course, the ethical approval was obtained, and inclusion criteria are as follows: surgical unsuitability because of multiple previous thoracotomy or the tumor multifocality, of course, the refusal of the surgery and the respiratory dysfunction. Of course, the oligometastasis of the lung is a good indication, I think. So this old machine have this cryo needle of this old machine. The tip is not so sharp, so we couldn't penetrate the lung tumor using this cryo probe. So we developed the puncture needle like this photo. This is a coaxial needle made by the stainless steel with the very fine 21 gauge guiding needle. We puncture the lung tumor using this needle. After that, we remove the guiding needle and the inner sheath. Then we insert the cryo needle into the outer sheath. So this is a movie. Usually, we use the intermittent 3-slice CT fluoroscopy to penetrate the lung tumor because using this 3-slice system, it's very easy to recognize the direction of the needle, so that we can adjust the needle very easily. Now the direction is a little wrong, so that we adjust the needle position. Now the guiding needle penetrates the tumor, and then we advance the coaxial needle over the guiding needle. Then we remove the guiding needle and the inner sheath and insert the cryo needle into the outer sheath. So next, I will move on to our result. All patients tolerate the procedure very well. The mean follow-up period was almost 900 days. The mean number of the cryo needle per session was 2.4. Of course, there is a complication after the cryoablation of the lung. Of course, the pneumothorax is very frequent, about 60%. However, we perform the CT scan immediately after the cryoablation so that we can easily detect a very minor pneumothorax. So this 60% include most of them are that kind of very minor pneumothorax. So among them, only the 10% of the patient need the chest tube insertion. And of course, there occur hemostasis. However, all hemostasis are self-limiting. This is a very nice case of the cryoablation of the primary lung cancer with interstitial pneumonia. So of course, as you know, after the surgery or after the RFA, there's a risk of the exacerbation of the interstitial pneumonia. So we selected the cryoablation. And finally, we complete the session and we follow up the 5 years. However, there's no recurrence of the primary lung cancer. This is another very impressive case of the young guys in his 30s. He has a multiple lung metastasis from the sarcoma. And most of the metastasis is located in the peripheral region. So the first surgeon performed the resection of the metastasis of the peripheral region in 3 times. After that, there remained one tumor in the central region. This blue tumor is remained. So this tumor is very close to the hepatic hilum, that in the pulmonary artery. So there's a very high risk of the injury of the pulmonary artery if you perform the RFA. So that we perform the cryoablation. Also, we inserted the cryoprobe very close to the pulmonary artery to prevent the thermal sink effect. Finally, there are no recurrence after the 2 years. It's a very fantastic result. So this is our result of the primary lung cancer, non-small cell lung cancer. So the local progression-free rate is 5 year, about 80%. Overall survival of the 3 year, 77, and 5 year, 67%. How about the stage 1 non-small cell lung cancer? 5 year of the overall survival is 74%. However, our result of the cryoablation of the pulmonary metastasis from the colorectal cancer is not so good. Local progression-free rate is about 1 year 65%, 3 year 50-60%. It's not so good. So now it believes that the lethal temperature of the adenocarcinoma from the colorectal cancer is lower than we expected. How about the tumor size? So of course, the smaller tumor, we have the very good result. So this is factors for local progression by the multivariate analysis of our case. Large tumor and large vessel near the target tumor is the main factors for the local progression. It's the same as radiofrequency ablation. So how about the ablative margin? So as far as I know, there's no definition of the ablative margin after the lung cryoablation because it's very difficult to evaluate the ablative margin for the lung cryoablation. So this is our paper. You can see, this is a CT scan immediately after the cryoablation. So you can see the central solid zone, zone D. Zone D, and also you can see the surrounding air containing zone, zone H. And in the central solid zone is completely necrosis. So, however, not in all cases we can distinguish between the zone D and the zone H. So, that as far as I know, it's very difficult to evaluate the ablative margin. This is a comparison between the cryoablation and RFA of the primary lung cancer. The result is almost the same. However, in our case, the mean tumor size is smaller than the RFA case. Of course, the result of the cryoablation of the metastasis from the colorectal cancer is not so good compared to the RFA. Thank you for your kind attention.
Thank you so much, Professor Masanori Ino, for your very comprehensive presentations. So before we discussion, on behalf of the local organization, we would like to give you the certificate of application.